Let's look at Caesar, a 1-year-old male entire Great Dane that's vaccinated and wormed, and it has got a third episode of diarrhea, anorexia and lethargy in a 4-month period. It's always improved with symptomatic treatment in the past.
On physical examination, his mucous membranes are pale pink and tacky, and his capillary refill time is 3 seconds, suggesting both hypovolemia and dehydration. His heart rate is 85 beats per minute, which is a relative bradycardia for a large dog in a stressful situation. Respiratory rate and temperature are relatively normal. He is mildly depressed and has some abdominal discomfort, but there are no other abnormal findings on physical examination. In a case like this, we have a number of different options. We could offer the client the option of further symptomatic treatment, which has been done in the past, but in a patient with an acute presentation but with chronic history, really we should be offering more at this stage, further testing and further treatment. So it's more logical to consider either a basic biochemistry panel such as a Chem10 and a PCV, or a minimum database. And let's start by looking at the sort of information we'd have got if we did a Chem10 and a PCV.
Let's look at results for Caesar then. So we've got PCV of 67, which is hemoconcentrated, and looking at biochemistry, we have a slightly low glucose, which is inappropriate for a sick patient, and we have elevated renal parameters, urea, creatinine, SDMA. So overall, this could all perhaps be linked to dehydration, but there would be other causes to consider.
So if we took a second option and we actually did a minimum database where we get more information, and we look at a full hematology, biochemistry, electrolytes and urinalysis, let's see what additional information we could have gained in this case. Looking at the hematology, we again see that we have the evidence of the hemoconcentration with the elevated red cell parameters. We also have a mild leukocytosis and a normal platelet count. And when we look at the white cell differential, or the leukogram, we can see that as well as the mature neutrophilia, we have a lack of some features that we would normally see in a stressed patient. So we don't have a lymphopenia and a eosinopenia. In fact, those values are well within the normal ranges. And so this lack of a stressed leukogram can make us think about diseases such as Addison's disease. When we look at the fuller chemistry panel, a Chem17, we can see again, as previously on the Chem10, that we have the mild hypoglycemia and the elevated urea and creatinine. But the additional information we gain here is that we also have hypercalcemia and hyperphosphatemia. We can also assess that the liver enzymes are normal, lipids are normal, and proteins are normal. When we look at the electrolyte results, we can see that we get a lot of additional useful information. We have marked hyponatremia and hypochloremia and marked hyperkalemia, which results in us having a sodium-potassium ratio of 17, which is very low and highly suggestive of Addison's disease. When we look at the urinalysis, which we didn't have when we just did the Chem10 and the PCV, we can see that now, when we try to interpret our urea, creatinine and SDMA, and we look at our urine-specific gravity of 1028, that this is not appropriately concentrated for the dog, and it again flags the consideration over the kidneys, but also over Addison's, because when we have a low sodium, the dog is unable to concentrate its urine adequately.
So overall, this patient is highly suspicious of having Addison's disease, and we should test for that. And we should consider performing an ACTH stimulation test and starting therapy directed at treating Addison's. Let's then look at the different outcomes for the possible scenarios that we had laid out. So in scenario 1, we've done a more limited biochemistry and a PCV, and the patient improved with fluid therapy with corrected hypovolemia, dehydration, and the blood tests after all returned to normal. Overall, we would have saved the owners quite a bit of money by performing a more limited profile, but we would have missed a diagnosis or a likely diagnosis of Addison's, and potentially this could end up being fatal for the dog. With option 2, we performed a minimum database, and we can see that looking at the hematology, we identified a lack of a stress leukogram. With urinalysis, we identified inappropriate concentration of urine in face of azotemia, and our electrolytes were markedly abnormal, and that's what made us suspicious or highly suspicious of Addison's disease and made us perform an ACTH stimulation test to diagnose Addison's disease in this case.
Addison's disease is a very rewarding disease to treat. It has great prognosis when identified early and treated effectively.